computer. All right. Hi, everyone. And I am really so thrilled to have Dr. Moore with us. Dr. Mallory Moore is a board certified specialist in swallowing and swallowing disorders, also a LANA certified lymphedema therapist, and an internationally recognized expert in the evaluation and management of dysphagia, head and neck cancer, lymphedemas, and upper airway disorders. She earned her Doctor of Speech Language Pathology degree from Nova Southeastern University and completed both her bachelor's and master's at Missouri State University. Since 2011, she has dedicated her career to providing advanced clinical care in outpatient rehabilitation and medical settings with expertise spanning from dysphagia to head and neck oncology, total laryngectomy rehabilitation, voice disorders, and complex airway management. Dr. Moore is also the first and currently the only speech language pathologist who serves on the board of directors for Lymphology Association of North America, which is LANA, where she continues to champion interdisciplinary collaborations in advanced care for individuals with head and neck cancer and lymphedema. Her commitment to improving patient care extends far beyond the clinic. Throughout her career, she has secured more than 307,000 in grant and foundation funding to expand access to instrumental swallowing assessment, innovative therapeutic technologies, and community-based rehabilitation services. I love that. She also serves on several nonprofit boards, amazing, including Larry's Speakeasy and Ozark Neurological Foundation, where she's passionate about mentorship, advocacy, and advancing the future of medical speech language pathology. Today, we will be exploring her expertise in lymphedema, head and neck cancer rehabilitation, lymphedema management, and the importance of collaboration, evidence-based care. Dr. Moore's passion for improving outcomes and empowering clinicians has made her a respected leader in our profession. And I'm so honored to welcome her in the Swallow Talk series. Dr. Moore, thank you so much for joining us. It's really a privilege, and we needed this for our
Oh,
field.
thank you. I'm excited to be here. And as I mentioned before, I really love talking about head and neck cancer care. And then the lymphedema management has been something over the past, oh gosh, I'm trying to remember when I even took the initial certification course, but at least, 5+ years. So it's something that I'm really passionate about. And I love talking about it with people who are interested. So.
That's so cool. The occurrence, I just feel like it's such an under-recognized area for our field.
Mhm.
Um, you know, um, like unless you don't really dive into the details, especially when the VFSs and the instrumental aspect comes in picture, it's really hard to even understand that uh, the symptom burden would actually be dysphagia. A lot of
Mhm.
people don't even know. So, I'm just going to start with what is head and neck lymphedema and, how does it develop?
Yeah, for sure. So, um, before we answer what's head and neck lymphedema, I kind of want to take just a quick step back and talk about what lymphedema is and
Beautiful.
what the normal lymphatic pathway is, because then we can really see where that burden comes over time. So, our lymphatic system, which it's so funny, when I look back at, my college courses, I think we just, maybe barely touched on it in our general anatomy and physiology classwork, but and I took, like a not even a speech pathology anatomy and physiology. I took, a general population anatomy and physiology because when I first went to college, I wasn't sure my pathway yet. So I thought maybe physical therapy or speech language pathology. I wasn't sure. So, but even in that aspect, it wasn't a heavily covered topic. So it's really neat to learn more and more about what it does. So essentially, it's this system throughout our entire body, and it connects directly to our circulatory system. It's all these very teeny tiny microscopic vascularities. It's these vessels that we have in our body, and it also includes we have certain organs that we consider part of the lymphatic pathway and tissues. But its job is to maintain this balance in our body. I think everyone in their life has a period of time where maybe there's more, your hands are swollen, like your rings are tough to get off, and or in pregnancy, your legs get swollen. And there's different types of edema. So that's, not all qualified necessarily, as a lymphedema, but our lymphatic system can play a part in it. So in addition to helping maintain this balance of fluid throughout our body, it also is a really key part of our immune system. So, everything, our lymphatic vessels, its goal is to get things through our lymph nodes. And our lymph nodes, it's the powerhouse for us for cleansing our body. It's looking at bacteria and viruses. And so our lymph fluid goes through those lymph nodes. And then we have our white blood cells and a variety of types that kind of activate and say, wait a minute, this doesn't seem right here. This pathogen shouldn't be here, and it starts working towards that. So it does a lot of really, really cool and interesting things for our body, and then it goes right back, goes through our entire body, and then even goes through our stomach, and then it comes back to our circulatory system. So it comes back to the heart. So it's pretty neat. So when it comes to any type of lymphedema, how that happens is that there's some sort of insult to this pathway to our body. So that can be like the tumor itself can be growing on those lymphatic vessels, and then the fluid doesn't have any place to go, and we start having swelling. So a lot of my like my salivary gland patients who have salivary carcinoma, one of their first symptoms is I have swelling right in this region here. Uh, Other reasons could be, so we have the tumor itself. When like a tonsil cancer or a lingual cancer, the excision to get rid of it, we're cutting through lymphatic pathways. And I teach a course on this with Chow seminars, not to self-promote or anything, but when I teach it, I always think about, I grew up in the Midwest in the United States, and I grew up more northern and then came further south. But I think about those snow accidents, when you get a whole bunch of snow and ice, and then they always have on the news they have the highways where it's like a 30 car pileup, right? And so
Oh,
then when you look at that big picture, and you think about, well, we have this original insult here, and then we have all these cars back here that are stuck. We can't just push these cars from the back through, right? It's going to just keep building up, building up, building up that fluid. So lymphedema care is learning how to, move those cars out of the front. And so the rest of that lymph fluid can come on through, or finding an alternative pathway. Um, Now, also lymphedema can occur from radiation. That can cause fibrosis of those tissues, scarring, and that scarring can also come from, the surgery itself. So there's a few different reasons why lymphedema can be pretty prevalent in the head and neck cancer population.
right. Yeah. I read a few articles and they said that historically, I did a little bit of my homework before. So I know they said that historically lymphedemas were primarily because it was like an after effect or an aftermath of the surgeries, but eventually over the course or over the last few decades or years, it has been an effect of the radiation and chemo that
Mhm.
really comes in. And I
Mhm.
think one of the studies said that it's within the 3 months of like 96% of the patient population usually have.
Mhm.
And that's why dysphagia comes into the
Sure.
picture.
Sure. And we can see those effects pretty early on, when someone is starting with their radiation treatment, and it's usually after the first like 3-ish weeks, 2 to 3 weeks, they start having a lot of swelling going on. And what our hope is that a lot of this, comes down by itself, just naturally, but that's not the case for everybody. And I've been doing head and neck cancer care for a while, and before I was trained with lymphedema care, from what our providers would tell us, I'd read their notes, I'd check in the recent, laryngoscopy, how are they doing, and it'd always say, no evidence of cancer, which, yay, that'd be the great thing. But then it would say normal post-radiation or post-surgical changes. With, they may mention swelling, and then here I come in and I might do video stroboscopy or my modified or something. And I would look and say, wow, they're really, they got a lot of swelling in there. But it was always presented as, well, it is what it is. And it's, and from one sense, yes, oh, sorry, my dogs are home. I'm at home. I'm really hoping they don't bark, but they're both looking at the door and I just heard them. So my apologies. But, in one sense, is it common after this type of intervention? Absolutely. But I think, as a team, we need to get better about saying it's common, but it's not what we want, right? It's something that we need to be working on so that we can help regain this function. And as when I was a newer clinician, starting all of this, it was just, oh, well, this is just is what it is. And sorry, my dogs, don't bark, puppies. Ruby, sorry. Oh, so sorry.
No, can you very much?
That
Yeah.
might happen a few times. I'm very sorry. And it's too hot to just put them outside. They would roast, so they have to be inside. So my apologies. But and where was I?
Um, we were talking about when you were a neuroclinician and
Oh,
you wanted to.
yeah, so even, at that stage and at that stage I was, partnering, we have a formal lymphedema clinic that we work really closely with. We're in the exact same building. And we were really at that time just focusing on external lymphedema. So if I didn't see someone with external lymphedema, I didn't necessarily refer that
Yeah.
way because I didn't even really think about the internal lymphedema. And, there's years I was working with even the laryngectomy population and even soon right after, they get their puncture and they'd be going up and down in size. And I would just say, it's normal. But I really didn't put that clinical emphasis and knowledge of, oh, it's your lymphatic pathway. And that's why we're having this. And now we know that we can do things to help reduce some of those fluctuations and get us to more of a stable level. But and in some of the, clinical cases, now I think we are doing so much of a better job of really diving into head and neck lymphedema. Historically, a lot of the lymphedema studies are out there for extremities, which of course
Yeah.
those are also
So physical. Yes.
incredibly important. But historically, that's been more of the focus. And I think now it's really great that speech pathology is getting involved because we really care about head and neck lymphedema because of how it affects swallowing, communication, and even cosmesis.
Voice. Yes, right. No, absolutely. I was just going to talk about that. You already kind of touched base on the external lymphedemas because it's more prominent, it's obvious, it's a swelling. You can kind of see it on the face, neck, mental region, jaw, visibly. But the internal lymphedemas, when it comes to, I think for me, I've seen the effects of squamous cell carcinoma on the posterior base of the tongue. That's primarily, and then obviously it goes down into the pharynx, the areopaglottic folds, epiglottis, how the invasion really affects also the arytenoids and so I think the internal lymphedemas are something that is you can only see through imaging or through the instrumental.
Absolutely. Absolutely. And that's, again, we have to advocate for better imaging, or, more frequent imaging if we can. And I know the struggle for the clinicians out there who don't have that access. I get that. And I've been at my main hospital for 15 years and it has taken, that time of advocating and talking to providers every day and working on upgrading our systems, of our actual equipment. When I first came and started working, our modified barium swallow stays were recorded on VHS tapes.
Oh, I
And
know. I've gone through that.
yeah, I mean, and and I think, now we're in the world of we've got this beautiful, we have great equipment now, and we kind of forget about where we started. But I remember turning the dial and just like
Oh God,
slowly
yes.
trying to review. And then I would have, if we wanted a picture, we'd have to take the VHS tape and take it over to, a different special equipment that would print out, one small square. And then we'd have to, hand deliver that sometime to the providers because we didn't have electronic medical records then. So,
And sometimes it won't even get recorded. So you will like,
yes,
oh, we pressed that record button. Oh, I think
yes,
it's
yes,
oh God, I
yes.
prominently remember those days.
Oh yeah. Oh yeah. Crazy days back then. But
Crazy.
but it shows how much we've come from and how well we're progressing. And I think physicians and providers, the more that we're partnering with them and educating them about how important it is to see this imaging, it really helps. And just this past week we had a case come in, and though the case was someone with esophageal cancer, and they were also healthcare providers, and a different clinician started with them, and then I ended up doing their modified, but they had to go through a lot of education with them still of, we need to do this study because they were wanting to progress, to get to a diet. But we need to do this study so it's not only just about are you aspirating or not, we need to do this study so that we know how to treat you to get you to your best outcome. And, and lots of education of, well, what if your epiglottis isn't inverting? Or what if your cricopharyngeus is really tight? We don't know that though. We don't know why things are happening until we can get that imaging done. But for those clinicians who don't have that access, I think, and it kind of goes back to what I was saying earlier with providers of how it used to be presented to me of like, oh, it's just normal findings. We need to be talking to them of, that this is a great report, but hey, what's really helpful for me? I need to know the severity and maybe sharing with them, some of the tools that we have, like the Patterson edema scale,
Yeah,
that can be really helpful. And, do you think you could incorporate that into your clinical practice? And, of course, you have to build those relationship first before you can, make that ask and everything. But those kinds of things really help us know what we need to do to treat these patients the right way.
absolutely. That puts me on to a great question in terms of, as you already talked about the physiological deficits of
Sure,
swallows.
sure.
So maybe like first five or the most prominent ones that you feel would be helpful for our audience.
Yeah. So, when it comes to lymphedema and really, head and neck cancer care, there's lymphedema and then there's, soon after we have fibrosis,
Yeah.
um, and with chronic lymphedema, that can turn into fibrosis. So we can get fibrosis in itself, from a muscular standpoint from the radiation, but then we can also get fibrosis from if the lymphedema is just sitting there too long. So we have to be really aggressive with our treatments. But from external and internal, there's different things that can be happening. So for an external case, somebody, especially with our laryngectomies,
Yeah.
um, they can have profound swelling of their face, their lips, and their tongue. They might not be able to even get oral closure because of how much swelling that's going, and their tongue might be protruded and be drooling.
Yeah.
So we can have severity from that standpoint. Their swelling could be so bad they might not even be able to open their eyes. It can be really severe in the beginning. So, having a team, even in that acute care setting, know what to do from a safe manner and gentle manner. Lymphedema care is very gentle, but having them get involved early to help bring that down can be very important for them. And then from an internal standpoint, typically what I see the most swelling or where I see the most swelling, submental space, which we can also see that externally, but you can see that on imaging, especially for X-ray. For you can also see the epiglottis. That's usually very,
Version.
very swollen. Yeah, we use and then we're having a heck of a time with getting that inversion there.
Yeah.
Um,
Yes.
yep. And then the arytenoid cartilages. I've seen some big arytenoid cartilages. And then with that, with even just those two key areas with how much swelling there is, usually the main issue is efficiency, right? And then the lack of
Absolutely.
efficiency, yeah, we get all of this residue in the vallecula sinus, and then maybe in that right on top of that arytenoid cartilage shelf in that inner arytenoid space or the piriform sinuses. and then
Yeah.
it just spills over, and that's where the aspiration event might happen. But you can hear it also in the voice. It can impact, it's not just about swallowing, and as much as I love just swallowing, we have to take care of the whole patient. So, there
Yes.
might also be voice, right? Or it could be airway. Just, gosh, it was probably a week ago. This case just broke my heart. They were just like, they're always the best families, they're just
Oh,
like the
yeah.
families you just want to hug and like be like, just come with me and I'll take care of you forever. They're just wonderful people. But this woman came in and she was peg tube dependent, pretty extensive. I want to say it was I think it was a laryngeal cancer that she had. But when she came for her swallow stay with me, she was so stridorous. I mean, when she was breathing, and she had profound lymphedema. I mean, of her vocal folds. Now, I did an X-ray, so I couldn't visualize the vocal folds directly on that. But I remember distinctly at the end of the study saying, I'm kind of worried about your breathing. I can hear you. I wonder if we need to, you know, get you over to the ER, or let's get you, can I take your pulse ox? Can I get your, vital signs before you go? I'm just a little bit, I'm a little worried about you. And oh, no, 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 I'm fine. I'm fine. And then I did a chart review a couple, like a week or two later to kind of check on them. And she had to go to the ER and get emergency tracheostomy placed because of the swelling. So it's, the swelling can be so significant that it can put you into a state of a medical emergency. So it's very serious.
It is. It's and then the important point that you brought in terms of like, the oral phase can be so impacted.
Sure.
Like, forget anything else. I mean, we all know pharyngeal phase is so important with all these swellings. And
Mhm.
I think I have firsthand experience of actually seeing it. It took me a while to understand that epiglottic wouldn't even like move. Forget like I was like, am I looking at this correctly or what? And
Mhm.
sometimes, as you said, the erythenoid cartilages are like so swollen that this water, because we were doing things like with trials, and it actually just like seeped in, and I was like, what is happening? But with the others, it couldn't even go. So every video fluoroscopy study can be so significantly different, and
For sure.
even for us speech language pathologists, it takes, we need to really figure it out because our deficits would impact the
Yeah.
treatment plan and how we're going to really try those pharyngeal exercises, if at all patient can even do, because if you have so much of swelling, there's no way you can even move, so there's so much happening, and the voice impact, so
Oh, absolutely. And
that's
it's nice to get the visual imaging too with fees. And I'm again, I know how lucky I am. I have access to both. I can do fees, video stroboscopy, modifieds. And again, I understand how lucky I am that I just have to make the ask. And it's very rare, knock on wood, that I get any pushback from the providers that I work with, because they know me, and we've worked together for years. And they know that it can make a big difference for these patients, and they know that I need this information so that I can help and I can treat them better. But fees also provides just a really fantastic view sometimes for you of the depth of the swelling, especially for the arytenoid cartilages. My goodness, there's been times that I've scoped, and wow, like there's no space there. So it really helps with that treatment planning and knowing, what do I need to do in this care.
Yeah, and also with the fees, you can actually just literally see pretty much, it's prominent. The
Oh
edema is
yeah,
prominent, the residue can be so prominent.
mhm,
So you can, there's more to it in terms of the physiology that you can
for sure,
understand.
for sure.
I was wanting to ask in terms of the assessment part of it. What usually, let's say, because, our talk would be, of course, for experienced clinicians, but also for students and, clinical fellows. When we evaluate patients with suspected head and neck cancer, lymphedema, let's say we don't have the imaging, or, patient just walked in, it could be an outpatient also. This is for
Sure,
the outpatient post-acute settings, because in acute care, we are like, everybody is so involved. We just have the
sure,
diagnosis right there. So,
sure,
what does a comprehensive assessment include? What
yeah,
external and internal findings are important, and
sure.
how can we go about it?
Yeah. So I'm in outpatient rehab, and that makes a difference for what part of like what you're saying, where we're falling in this plan of care. But most times, these referrals, we already know that they have a cancer diagnosis. And in outpatient, it's kind of, I mean, I don't know, you could say it about any field, any area, but I feel like it's the Wild West sometimes. Like, you have like this paper diagnosis and you're like, okay, I think I know what to expect. And they come in, you're like, oh wow, this is different. This is not what I was expecting, right? Um,
Yes.
so, we get such a variety of cases. In a very small percentage of cases, I might get a referral for someone whose first diagnosis is like a voice issue. And then I might do a video stroboscopy and say, ooh, we need to get you to the ENT today. And it's like a laryngeal carcinoma. So that's more rare. Usually those cases have been identified first, but every once in a while we might be the people to see something and say, wait, that's not right. We need to get you to the ENT. Most cases, though, and we worked really, really hard to get to this stage, is most cases are now those cases that have that early diagnosis. And in the ideal world, too, they have not yet started their chemo, radiation, or surgical journey. They have just been kind of teed up and they know that these things are coming, but hopefully they haven't happened yet. And that's my ideal case. And the reason why is because I get to do a really nice thorough assessment. And then I'm also a big believer in Farango size. Let's get you exercising before. Let's try to get this, let's get your reserve up beforehand. So in some of those cases, they may not have any big concerns going on. Sometimes, we live in a rural area. Sometimes people don't have good health insurance. Sometimes patients are just kind of afraid to go in because maybe they're chronic smokers and maybe they've noticed some changes over time and maybe they kind of have that fear of the unknown. You know what I mean? They kind of think like, oh, maybe I have cancer and I just am gonna, put my head
Let's
in the
know about it.
credit,
Yeah.
I'm just gonna ignore it. And so sometimes we do get those cases that come in and they are having a lot of problems already because the tumor has infiltrated some of those really key places. But again, the ideal situation is they don't have a lot of symptoms yet. We've identified it and we can get going. So typically that referral looks like a clinical swallow evaluation, but I'm still being really thorough. No matter where they are, I'm going to get some key things. So I'm always going to do a cranial nerve assessment, which, okay, I think I shushed them for a moment. So I don't know what happened. A squirrel. I don't know.
That's okay.
So, um,
Okay.
so, cranial nerve assessment, which includes, a very thorough look within the oral cavity. It's also going to include, I'm going to do a trismus rating. So, if you have access to I use the Therabyte, their little measuring, excuse me, I use that. And
Uh-huh.
that gives me an exact millimeter opening. If you don't have access to that, you can do the three finger method. Ideally, someone's mouth, should be three finger widths or more. And then, if less, then you can say it's about two finger widths, one finger widths, or, whatever it might be. And that can give you, a more of a subjective type measurement, but still helpful. Um, I'm looking at oral health. So, sometimes I get patients that have maybe already started their radiation and maybe they have some mucositis going on or maybe some thrush going on. Now, we can't diagnose those things. That's a medical provider, but I can say, hey, I'm noticing a white coating across that seems to be consistent with their thrush, and I'd like you to go see your provider for it. Or mucositis. This seems consistent with mucositis, which is more common after about 2 weeks of radiation therapy, and it usually clears up over time. But even for those prophylactic patients that don't have any of that at that point, I'm still giving them education. I'm a big believer in the honey for these patients. I think that helps a lot for them. A lot of my patients who listen and do it, they usually say, wow, like I haven't really had that much trouble with sores in my mouth. So just from clinical perspective, I think it's great. What else do I do? And then I do a lot of measurements. I use the MD Anderson methodology for measuring. And so that's, kind of a wide variety. I do the right side of the face, the left side of the face. I do some, neck measurements here,
Congratulations.
circumferential measurements. And it's even if they're not having any swelling, that is key baseline information in the world of outpatient rehab. The nightmare of getting visits covered. I have one person on caseload right now. We get 4 visits at a time. That's all the it's just, I'm
Don't
like,
really get that.
just like, and the amount of time then I have to take away from a treatment session to then redo some of these measurements to then advocate, hey, I need more.
Yes.
But the more options that you have for that baseline information, the more you can utilize that for advocating for more visits if you need them. So I get that.
Nice.
I know I'm going to forget something. And I feel like there's something obvious right in front of me that I'm forgetting. Um,
It's okay. It'll come,
you're
it
right.
just,
It's gonna be in the
yeah.
middle of the night. Middle of the night, it's gonna pop up, and I'm gonna say, "Oh yeah, this is what's
Oh
so
God, it
obvious,"
happens. No,
Um,
but I think you gave a pretty good overview in terms of like the main
yeah,
the key the main assessment points for a
yeah,
pathologist.
yeah,
And I absolutely love the whole outpatient settings and how it's hard. It's
mhm,
we all know how much you have to talk to the insurance case managers, and you advocate for our patients, and really write robust clinical notes that
yeah,
hey, it's really needed.
yeah.
So
And
that aspect is
it's
important.
kind of funny when it comes to the clinical swallow for some of these cases too, because sometimes the least priority for me is actually food and liquid trials
Yeah,
when it's a prophylactic case, because my priority is
yeah,
educating them, getting my baseline and educating them. And part of it is trusting them. Like, I'm eating fine right now. Well, I believe you.
yeah,
There's not too many people that I'm like, well, prove it to me. You know what I mean? So
yeah.
and
No,
in certain cases, yes, having them actually do more, food and liquid trials can certainly be helpful. And I can kind of guide of, well, let's try maybe a placement here. Or let's try, wow, that was a big drink. Let's maybe try smaller drinks and everything. But in those ideal cases where it's they're doing pretty good at the time. Some of those food trials are just kind of on the bottom of my to-do list. I mean, I'll usually have them drink a little water with me and everything and see how they're doing, but I don't make them eat like a whole tray of food.
no,
That's
yeah.
not my priority at the time, which I think when you're first starting out and you're learning about the clinical swallow and we got to do all of these different trials, which yes, can be appropriate at the right time and place and can be very valuable, but we also have to learn this flexibility, right?
Yes. And it's
Um,
like they must. I think I brought that point in my previous talks that, we were like, let's do the peer trial. It's not always needed. It's the need of the hour. It's looking at what the
yes,
patient needs. And
yes,
I think with lymphedemas, it's a lot education because patients literally don't even know, as I mentioned about the swallow burden, the symptom burden of lymphedema and how
yes,
it can impact and a specialist needs to really make them aware that over the course or down the lane, this might can happen, and
yeah,
you have to really keep a close check on all these swallow functions and how it can
for sure,
impact. So,
for sure,
absolutely, education is so important
for
on
sure.
this.
Yeah.
Um, yeah, in terms of the treatment, so
Mm.
let's see. For SLPs who are new, I mean, for managing head and neck lymphedemas, what are the functional treatment principles that you would use?
Yeah, so the gold standard for treatment for lymphedema is called complete decongestive therapy. And a lot of people might just write it as CDT. And um, there's 2 phases to it. There's the traditionally the intensive phase, and then there's the phase 2, which is considered more non-intensive and they're more stabilized. But they really kind of mold both back and forth with each other. So, traditionally with CDT, patients are seen 4 times a week for 4 weeks. I don't know too many insurance companies that cover that. Also, Availability. Sometimes that's really challenging too. In the ideal world, would I love to see my patients at that intensity? Absolutely. But that's not always the case. And I also work part-time. So I physically can't see the patients, 4 times a week. So I rely on a heavy partnership with the formal lymphedema team, my PTs and OTs. So I think that's really important for them too. And I tell all my patients, like, you're going to see me and I'm a lymphedema therapist, but I also want you to see these lymphedema therapists because they're looking at you from a different lens and it's just as important and you can't ignore it. You need it, you have to. So I'm really big on that multidisciplinary collaboration for them. Um, but when we look at complete decongestive therapy, the main kind of areas is skincare. So people who, and we wouldn't really think about that normally, but people who have lymphedema, they are just more prone for infections. So we really want to we're going to be keeping an eye out for any signs and symptoms of infection. We're also going to be encouraging them to do like a very neutral pH lotion to help support the skin and its healing. And I can hear Ruby growling, my dog, so she might bark loud, Ruby. They both just looked at me, but I hope that was enough to stop them. So skincare. And if someone has an active infection, which I've had that in the head and neck region, I had someone who had just the cyst area that would keep coming and it would get infected. And there are times for therapy when we're concerned about an active infection, it's a no.
It
I'm
is.
not doing manual therapy because that could spread the infection. Um, but I might do other things in session, more traditional type dysphagia exercises or voice exercises, but I'm not going to do hands-on work until they're getting a medical
Done with it.
evaluation, they're being treated. And manual lymphatic drainage. So that's a form of manual therapy. That's the hands-on therapy. So it's a type of massage type work. It's very, very gentle. Okay. I mean, it's what I was first trained in was myofascial. So real,
I
deep work into this fibrotic tissue. And that's not necessarily what it is. And there's certainly time and a place for that myofascial work, but that takes time and experience and also learning, is this, lymphatic tissue that I'm dealing with that we need to move this fluid out? Or is this really tough fibrotic tissue where I can get a little bit more aggressive with my treatment here? So we have those two parts. The other parts that we have is compression and exercise. So compression, that can look like bandaging, and it's not with an ACE wrap, not a call out for ACE, not for a long stretch bandage. It's specific to short stretch bandages.
okay.
And for me, an outpatient, I don't have as many people who are willing to do the short stretch. And so I am usually putting them into a garment early, very, very early on. And there's over-the-counter garments that can be fairly cost effective. And there's also, there's grants out there sometimes to help cover the cost. My hospital has like a foundation available that, if I were to go to and say, this patient has financial hardship and they have to submit financial paperwork and everything, but we need this because of X, Y, and Z. Sometimes they will cover the whole cost or part of the cost. So there's always a way. So the garment, after we do all of our manual lymphatic drainage work, if we don't give that compression to it, and again, it gets into you really need to know more about the lymphatic system. But if we don't get into that compression, that lymph fluid's just going to come right back. So we have to compress and help encourage that lymph fluid to get back into those lymphatic vessels. And then exercise. So and in our field, again, this is one of those things that I mean, research, I think, is just it's gonna blossom and flourish, I think, over the next 5 to 10 years for speech pathology in this, and looking into what exercises specifically are going to benefit these patients best, specifically for the lymphatic part of it. Now, I utilize like our traditional, types of dysphagia exercises, but I encourage them to do that maybe with their garment on, or maybe with their pneumatic compression device on, and have them try to do that at the same time, and that can help. A phrase that we use in our Parkinson's group that I work with, we have a Parkinson's clinic at my hospital, but the big phrase is motion is lotion, and I also believe that for head and neck cancer, motion is lotion. We need to get these muscle groups moving. So, and what else better to move lymphatic fluid than swallowing.
Absolutely. Yeah.
Right?
Because
You know?
you're treating the main cause to help navigate the swallowing.
Yeah,
That's
absolutely. We
amazing.
can't physically put our fingers down there, nor would I want to. You know,
Yeah.
so those effortful swallows, the Mendelssohn maneuver, and anything, pitch glides, what we can do to help compress the vocal folds, get them moving, get that epiglottis inverting when we're swallowing. And we also say, just in general, I think in the swallowing therapy, the best exercise for swallowing is swallowing.
Keep swallowing.
We need to swallow. So, um,
Yeah.
so yeah, so those are the different main stages that you go through. And it's really important for clinicians, if you're interested in doing it, to get the appropriate training for it. It's so important because, with any type of intervention, there can be indications and contraindications, but especially for this population, if you don't understand the appropriate lymphatic pathways, it could be encouraging the lymph to just stay in a certain area,
It might
right?
just, yeah.
Yeah, just getting worse.
It might just
Yeah,
hit.
yeah, absolutely.
Absolutely. No,
So,
I really liked about that lymphedema causes inflation.
mhm,
Then the inflammation promotes fibrosis,
mhm.
and fibrosis further reduces tissue flexibility, muscle contractions, swelling movement. So all these treatment really would help because we are actually treating the cause and, gradually hoping that the swallow functionability also improves. Beautifully explained, and I think this is such a brilliant conversation and discussion. Also, creating awareness within the speech language pathology field, as I mentioned. If you haven't come across a patient with head and neck cancer, you wouldn't know that SLPs play such a vital role in this treatment, in this patient population for the treatment. Yeah.
Absolutely. Absolutely. And there's a lot of training opportunities. And I don't ever want to be biased, but I did write down a few of them that
Sure.
I wanted to share for people if they are interested in further training. I know I wrote it down here somewhere. Oh, darn it, of course. Where did I put it? I put down notes off to the side for myself today, and then of course I lost track of where it was. Um, but
Way too bad.
life of a mom, I'm always losing track of things. So, but there,
No
there's,
problem.
let me see. So there's training where you can go to like a specific head and neck course, okay, for
Okay.
speech pathology, and you can focus on learning specific lymphedema intervention for head and neck. I teach a course with Chow. Lauren Methin has her own business and she's partnered with Brad Smith. Brad Smith is like the founding father for us for speech pathology and head and neck lymphedema. So,
That's amazing.
bow to him. He's amazing. I can't say enough about him because he was the pioneer breaking us through into this, and he's awesome. So they put on a really great course together. Um, and then there's different schools. So like when I went to be a certified lymphedema therapist, I went to the Norton School, but there's also Close, there's the Academy of Lymphatic Studies, and um, most of these schools have specific head and neck courses. So
Mm.
you can choose to go and be a full certified lymphedema therapist. Okay. But then you could also go to one of these specific head and neck lymphedema courses, but you're not a certified lymphedema therapist. So
The difference between that's
but that,
really yeah.
yeah, but that's the main difference. So I encourage speech language pathologists. I think becoming a fully certified lymphedema therapist is great because you get that full body knowledge. And it really helps with just a holistic approach. Even with, I might get a voice patient, and we're talking and I'm going through their medical history and I see that they're a breast cancer survivor and I'll say, oh, well, how you doing? And because of my, background, I'm like, how's your arm? Like, are you doing good? Are you getting any swelling in your arm anymore? Oh, actually I am. I'm like, oh, did you ever get to work with our lymphedema team? You know what? I did, but it was 5 years ago. And, my garment really doesn't fit, which those garments should really be replaced every 6 months. And I'll say, let's get you over there. So it again, it helps with that holistic approach for these patients. for
Yeah.
sure.
And identifying them, because most
Mhm.
of the time it would just slide through and nobody would even know. So
Yeah.
it's really good.
Yeah.
Um, I have this really burning question, let's say that, in terms of
Okay.
the advancement. So looking at the bigger picture, what do you think, what are the most common misconceptions or clinical mistakes you see in lymphedema management?
Yeah. Oh, I'm going to choose my words carefully.
And
So I think the thing I see out there that I'm working on this on myself, that I do not have to be the person to point out something wrong. Sometimes I just have to let things go. But I see I see a lot of people on social media
yeah.
that claim they're a specialist in lymphedema. And they're,
Mm.
giving kind of these social media things of like, oh, if you're massage right here, this is going to do X, Y, and Z. Um, and I'd say like 70% of the time it's wrong that I'm
Wow.
seeing. I mean, and some of the things are right, but like the technique is wrong or what we're addressing is wrong. And it just and again, that's not speech pathology really that I'm seeing do that. It's other types of healthcare professionals. Um,
Mm.
but I think it's a disservice. It's kind of, yeah, I'm just gonna try not to like put myself into a bad area. But you see things on social media that says like, "Oh, take this vitamin and it's going to cure your speech, your
Oh,
child."
yes.
Like, speech pathologists around the country are saying, but that it goes to, I see this and I think about my PT and OT colleagues who have gone through the appropriate training and I'm like, here's this person that does not have the education. And I've even gone down the rabbit hole sometimes of like, okay, I need to see, like, is this a certified lymphedema therapist or like what is this person's
Yeah.
background? Like what's going on here? And they don't have that educational background. And so people can go on social media and claim to be
Who they
the
are not. I'm
these
sorry.
specialists and they're not, and then they're giving bad advice. So that's what can be, I think that the I guess one of the big things is watch out for those people. And if you're interested in this, go to people who have taken the time who have learned the anatomy and physiology, who have gone through training, who are very passionate about this, and please don't base your training off of a random person on social media who might be claiming something that's not true.
Not
And
even true. Yes.
yeah, and it's hard, and I think because my feed, because of what I do, I get more of that on my feed, which is fine. And sometimes it's like, oh yeah, like that's kind of a cool technique, and I can see, I see the lymphatic pathways, and I can understand that, and that is correct. But other people, I'm like, that's just wrong that they're teaching. Like that's just
Outrightly wrong. You can
yeah,
totally.
it's just outright wrong. Yeah. And
Yeah.
then sometimes I'll get patients now. I get younger and younger patients, those HPV related cancers, they're younger patients and they go on social media, which, with how long it takes them to get into see providers, and sometimes their insurance restrictions, like I don't blame them. But then it's a lot of education of like, well, that's right to a certain extent, but let's maybe do this instead.
Yes.
So it's a lot of education.
It's a lot of education. No, I think those were really brilliant points that don't just go on social media. Whatever you hear and
Yeah.
see is not what needs to be followed through. Please,
Yeah.
please, please go to your specialist, go to a certified practitioner who is really informed and who understands this and will give you that's how it's pretty much how the chin tuck is. It's everybody's like, oh, just tuck your chin down and I'm
It
like, oh
doesn't always
God.
work.
It doesn't
Yep.
work. And then everybody wants to be a speech pathologist, I feel like the
Oh yeah.
nurses and the other. And I'm like, okay, fine,
Yep.
sure.
Yeah.
Sometimes you just have to step back.
I know. I know. And it's, pick your battles and, how can I come this from a place of kindness? And, it's, yeah, It's a lot.
No, but I really, once again, I truly want to thank you. This was so fascinating, amazing, and I really hope that all of us, our SLP community, really listens and hears this and understand. That's why I went like, and you beautifully explained the fundamentals and basics, because this is a wide audience we are dealing with, from
Yeah.
students, from clinical fellows, early clinicians, early career SLPs, obviously advanced, and everybody would know. But also, I think the way we dived into the questions was like a complete overview of what we
Yeah.
would do as a speech language pathologist. And
Yeah.
it's amazing. It's such a wonderful thing that you're doing. Like
Oh,
we need people like you for our in the
oh,
field.
well, thank you.
To-
That's so kind.
Yeah, thank you once again.
Yes. Thank you for having me. And I really appreciated this today. This was great.
Thank you. Thank you.